I'll quickly go through the case so we can have more time for discussion. Our patient was a 50-year-old male with a background history of diabetes. He had been consuming alcohol in serogenic doses for 25 years and was diagnosed with chronic liver disease in 2016 when he had a varicose bleed. Within the next 2 years, he had decompensations in the form of bleeding and resistant ascites, which required multiple episodes of paracentesis. His MELD score was 29. Because of decompensations, we offered him liver transplant. And his donor was his wife, who was an ABO identical donor, O positive. She's a 44-year-old lady.
Shweta, can you put it on slideshow, please?
Yeah, okay. So the donor was the patient's wife, who was 44 years old. It was an ABO identical transplant. The graft was modified right lobe graft. It was a non-fatty graft with normal anatomy. The GRWR was 0.893. Intraoperative period for the recipient was fairly okay. It was an uneventful explant. The warm ischemia time was 20 minutes. Cold ischemia was 145 minutes. There was no documented reperfusion syndrome. Implant was straightforward. It was single duct-to-duct anastomosis. The patient was with us for 12 days in the post-operative period in hospital, during which his serial Doppler scans, his labs were all within normal limits. He had an uneventful recovery. If you look at the graph, you will see that the bilirubin level, enzyme levels, they all come down towards the end of his hospital stay. As far as immunosuppression is concerned, induction agent was basiliximab. For maintenance, we gave him tacrolimus, which was started at 1 mg per day and was increased to 3.5 based on his TAC levels. Along with that, he received mycophenolate 500 BD. The next slide will show you the TAC level, which increased from 1.272, and then finally by discharge, he is at TAC level of 3.2.
At this point, can we ask Dr. Joy? Is Dr. Joy there?
Yeah.
Dr. Joy, what would your protocol be on TAC levels and immunosuppression? A quick word on that before we proceed with the case.
Yeah. Normally, if you are not using the induction therapy like basiliximab, the TAC level we used to keep between the 6 to 8 in the immediate post-transplant period. Mostly the third TBD onwards, we will start the mycophenolate mofetil. Most of the patients, the steroid, we know the tablet prednisolone will be there, and we will slowly taper the prednisolone after discharge. Mostly we completely stop the prednisolone at the end of 1 month. This is the normal protocol. Whenever we are going to use the induction therapy like basiliximab something, so we can start the tacrolimus, the tablet very slowly in the third PBD, and we can slowly increase, because our concern mostly in the renal sparing, it comes as one of the renal sparing. So we can slowly, we can see the patient's urine output, renal parameters. Based on that, we can tighten the dose. Here, this particular case, if it is, at the time of discharge, they are mentioning the TAC level is 3, because in case in the immediate post-transplant period and intraoperative in the period also, there is no major renal dysfunction, my suggestion would be better to maintain the adequate TAC level. We can reach even up to between 6 to 8. And along with already the patients, they ordered the mycophenolate. That's a good thing. So that will be my comment on it.
Thank you, Dr. Joy. We got the message. So you do not use a steroid sparing regime. Basiliximab is used sparingly. We'll move on with the case. Over to Dr. Shweta.
So the next, over the next 1.5 months, we saw him as OP visits. He was doing reasonably well. He was on Advagraph, mycophenolate and azurin, because mycophenolate had to be stopped as he was having diarrhea. The TAC level during one of the visits was less than 3, so we increased the dose of Advagraph from 3.5 to 5. And after stopping mycophenolate, we added azurin 75 mg OD. So up till now, he was doing reasonably well. His problem started about 1.5 months later, where he presented to OP with severe pruritus and jaundice. There was no fever. USG was done in the OPD, and that did not show any vascular issue. There was no IHPRD, there was normal ecotexture. If you look at the labs, there has been a steep rise in the bilirubin at this point, which is at 21. OT and PT were 1100s and 695 respectively. Alkaline phosphatase is 388. His TAC level is 11.8 0.03 nanograms per dl.
Dr. Dharmesh? Dr.
Yeah,
Dharmesh?
can you hear me?
Yes, so this is the picture with which he came to the OPD. We would like to know what would be your thoughts on this, how you would proceed, admission, further tests.
Right, so this gentleman has primarily presented with pruritus and probably coluria and scleral tinge, and the Doppler is showing that there are no plumbing issues. The striking thing is that this gentleman always used to have a low TAC, even though he was switched from standard tacrolimus to Advograph, and the dose was high, but if you see the TAC level here, it's 11, which again is a little surprising because even at the time of discharge when he's on 3.5 milligrams per day, the TAC level is, so there cannot be one-to-one correlation between the TAC level and the dose, but in a given patient you will see a kind of a set format between the two. So here suddenly this has jumped to 11, and his enzymes are obviously very high, about 25 times upper limit of normal. ASP is more than ELT. Again, we should go back, revisit the viruses, anti-core total positivity in the donor as well as in the recipient. I would get a viral screen done for this patient, including A and E, even though AST is more than ALT. And I would also take a very cautious history from the next of kin of drug default. So if you were to ask me this question, I'm absolutely sure that this guy has defaulted on drug. And I will take other people's opinion as to why I'm so dogmatic about this statement. No need for hospitalization. If Doppler is good, I would just go ahead, do an INR and biopsy him and take it from there.
Thank you, Dr. Dharmesh. So we'll move on.
So we had rejection in our mind, and at this point we chose to perform a biopsy. I have the biopsy images with me on the screen. Can we ask Dr. Malini to give her insights as to what she saw in this first biopsy?
Dr. Malini?
Dr. Malini?
Yeah, can you hear me now?
Yeah, we can hear you.
Yeah, fine. So it was basically something that was looking like an acute TCMR with both endothelitis and with ductulitis with a mixed inflammation. And I think it was an RAI of 6 to 7, if I remember right, or 7,
Seven.
Yeah, 7 or 9, yeah.
Okay, so an area of 7.7 by 9, we thought of moderate rejection, and at this point we pulsed this patient. We gave 1 gram of methylprednisolone over 5 days.
Again, back to Dr. Joy. Dr. Joy,
Yeah, please.
what would your protocol be? Do you give methylprednisolone? Is the choice of steroid methylprednisolone or Dexona? Any thoughts on that, the dose?
So always we used to give injection methylprednisolone. It's 1 gram. If the proven, the biopsy proven, the ACR, we give for 3 days. Meanwhile, we will keep that adequate track level also, and the patient will be on the MMF. This patient is already on Asaron, so we have to continue this Asaron as well as the tacrolimus. We have to keep adequate level, and the patient should be on the CMD prophylaxis.
Okay, thank you.
Okay, so after pulsing, the bilirubin levels did come down for a while, but what was worrying is that as soon as it came down, within the next couple of days, it started going up again. So from 17 it starts going to 21, and within the next few days it's reached 27. There is increase in enzyme levels as well. Alkaline phosphatase is around 200 to 300 at this point. So we did think that there could be a possible biliary issue in the background, and we performed an imaging. The MRCP showed a biliary stricture at the anastomosis. Because patient was severely symptomatic with pruritus and jaundice, we decided to go ahead with an ERCP. ERCP also confirmed a stricture which required balloon dilatation, and 2 stents were placed both in the anterior posterior sectors. After the stenting, this is the first time where his bilirubin levels dropped from 27 to 22 within 3 or 4 days, and he had some relief of his symptoms. So his itching did come down to a certain extent. So we decided to discharge him, and at discharge this was his immunosuppression. Advograph was brought down from 5 to 4 mgOD. Vicelone was given in tapering dose, 20 followed by 30 followed by 20, and we decided to add everolimus 0.25 BD.
I would like to invite Dr. Charles. Dr. Charles? Am I audible?
Yeah, we are audible, please.
Okay. Charles, what are your thoughts now? There was a not so difficult stricture in the bile duct. Anup could traverse it easily. We stented him. And then patient was okay, still cholestatic, otherwise fine, planning to discharge. So what would be your immunosuppression protocol at this point of time? Do you agree with this?
I would ideally rebiopsy him before sending him home, because you had a severe rejection. They are not seeing much response with 1 gram steroid for 5 days. So before I would rebiopsy him, look at the response to the steroid, and then optimize the immunosuppression further before sending him home.
Even if you see a biliary stricture on MRCP, you would go ahead with the biopsy first?
Yeah, see, the first biopsy showed acute cellular rejection is 6/9, score of 6/9, and you have seen that the bilirubin is high, enzymes are high, and you are constantly giving him steroid for 5 days. Even if I see a stricture, I would like to biopsy him and make sure that he has responded to your steroid therapy.
Okay, yeah, point taken.
Can I make a point here? Hello, can I make a point?
Sure, sir.
Yeah, sure.
So I think in the initial biopsy you have not commented on the bile ducts. In fact, I think what somebody made a passing reference was to the fact that in some portal tracts you are not able to see the bile ducts.
Dr.
Can you revisit
Danesh,
that?
Dr. Malini had commented that it's an acute T-cell mediated rejection. She was not suspecting
Yeah.
a biliary pathology on biopsy.
So that's what. So if you have somebody who's got a significant stricture, that is something which would show up on histology
Correct, yes.
far sooner than what we would expect to see on an MRCP. So I think it's a difficult thing to buy that this patient has got a stricture-related pathology. That is something that a pathologist would never miss on a biopsy. You will see a ductular reaction, which is not present here. So I would be a little averse to believe that this is a stricture we are dealing with. You don't get such high enzymes in strictures.
Thank you, sir. Thank you. The point is well taken. Thank you.
So we thought that he was getting better, but within 7 to 8 days of discharge, he again came back to us with worsening of his jaundice, worsening of pruritus. Ultrasound again was normal. CMV was sent at this point, which was negative, and bilirubin was at 28 by now. OTPTs were in 400 and 500. Alkaline phosphatase was 283. So we thought of rejection again, because just 2 weeks back his biopsy showed ACR, and again we did pulse him with 1 gram of methylprednisolone, which was given for 5 days. So what was worrying again was that it did come down to 20 and 18, but then again it starts climbing up. So at this point we decided to do a second liver biopsy to see if we are missing something. Dr. Malini, could you comment on the second liver biopsy? Was there anything different that you saw?
Do you want Dr. Rachel to take this question, because I've shared the images with her.
Definitely, yes.
Sure, yes,
yeah.
yes.
We want a second opinion from Dr. Rachel
Yeah.
Brown too. Yes.
Thank you. Can you pop the images up, please, from the second biopsy? Thank you. So I think certainly on that first biopsy, there was central perivenulitis that was really quite florid, wasn't it? And obviously I've only seen the images, so I've not seen the whole biopsy, but it looked like the portal manifestations of rejection at that point were quite mild, and it was predominantly a central perivenulitis. And that's a picture that is recognised, and certainly in some early work that was done in here in Birmingham, we worry about that central perivenulitis lesion as a potential harbinger of patients who are going to progress towards chronic rejection. So I think it's hard always to reflect that in a rejection activity index, but a florid central perivenulitis like that, we're always concerned about. As my colleague has pointed out, we're not seeing the peripheral manifestations of large bile duct obstruction on that first biopsy. On this second biopsy, I felt now in the images here there is damage to bile ducts. So particularly in that image on the right-hand side, it's a little difficult to determine whether we're looking at a duct or a ductule. Nevertheless, I think we probably do have a duct proper in here. That's the artery, that's probably the bile duct. And it's looking very severely damaged, almost dysplastic. So I'm worried about a progression to chronic rejection at this point. I'm not really seeing acute rejection, but I note you've taken this biopsy after you've treated, which is not ideal. So it's highly likely that the appearances here have been modified by treating first and biopsying afterwards. It would always be ideal to do it the other way around if possible.
Dr. Brown, why is central lobular injury not accounted for in the rejection activity index? It's not part of the RAI, so isn't it important that central lobular injury is recognized early?
Yeah, I mean, it is, because you account for endothelitis occurring in the central vein as part of your overall endothelitis assessment. But sometimes if you are applying an RAI, your portal score is going to be really quite low because there wasn't much portal inflammation. There didn't seem to be very much bile duct injury either, so that's a low score. So you're going to get maybe a 3 for your endothelitis, and then when you add that up, I think I only would have got maybe as far as 5 on a rejection activity index, but I would have reported it saying it's best regarded as severe rejection because it's a florid central perivenulitis. We can't, numbers, I'm not a huge fan of numbers. They serve a purpose, but we're looking at biological variables here that don't follow a numerical scale. So I think we should just be a little bit reticent about, I know my colleagues love numbers. It's easier to look at a number than to read a couple of sentences on a pathology report. I'm being rude there unnecessarily probably, but that's so I would have regarded the first biopsy as severe and probably T-cell mediated rejection, but I would have, with that central perivenulitis, I would have been writing on my report, have you checked a donor-specific antibody? And then this second biopsy, it's post-treatment, which is not ideal, but there are features here now that are concerning for a progression to chronic rejection.
Thank you, Dr. Brown. Can we ask our hepatologist, Dr. Dharmesh, are you there?
Yes, I am.
With what Dr. Brown has told us, what would you be thinking of now? The second biopsy
Right, so first I would echo her statement that we should have biopsies before pulsing.
Yeah, I agree.
And obviously the stents would be a kind of a confounding variable in this. So that's why somebody's already been stented, and at our center, if you get a patient from another hospital who's been transplanted, first we would remove the stents and then give some lag period before we biopsy and then take the things forward. If you also see the otherwise the lobules are quiescent, and such patients generally they don't respond very well to steroids. So steroids have a kind of a stunning effect on the lobular inflammation. You do see some changes of the bile duct epithelium senescence, like Dr. Rachel said, that this is probably indicative of progression to chronic rejection. So one has to be very careful. More portal tracts should be studied, and if somebody is developing florid ductopenia, that means you don't see ductules at all, then that is the time that you have to really nuance your immunosuppression. So if you see these senescent changes, that gives you some hope that you might be able to get this graft back on track and you could probably retrieve it. But if you see that portal tracts are devoid of ductules, then you have to completely change the immunosuppression protocol.
But what would be your protocol now for immunosuppression?
Right, so this track has been, so I didn't quite understand your statement in the first instance of 1 gram over 5 days. So I don't know whether you were trying to say 200 milligrams for 5 days. So what we do is 1 gram, 3 consecutive days, and then we bring it down to 20 milligrams, and then subsequently you keep tapering it by 5 milligrams every 5 to 7 days. And if you find that this is the general trend, so the person who was presenting, so you do see an initial decline in bilirubin and the enzymes, but when the type of rejection is what you are seeing in this patient, I would have added a more liberal dose of an mTOR inhibitor right in the beginning. And like I said, you have to be keeping a very close watch on infections. When you're putting on an everolimus chest X-ray, any symptoms of cough, respiratory symptoms, you have to have a very low threshold for all of these. Quite a few of these patients will also develop rapid features of decompensation. So they might begin to form ascites, which might be only ultrasonologically demonstrated early on. So one has to be very careful when patients are on
Okay,
such
Dr.
high
Dharmesh, thank you. Dr. Charles, are you there?
Yeah,
If you consider this, that the 2 steroid pulses have been given and then you get a biopsy like this, will you consider this a steroid refractory rejection, and what would be your plan after this?
yeah. See, you have given the initial pulse of 5 days, 1 gram 5 days, which normally, as Dr. Ramesh said, we don't do that. We give for 500 milligram for 3 days and then taper. And the second pulse also has been given and patient has not responded. And there's some evidence of chronic rejection in the biopsy. Our protocol would be to give him ATG.
Okay, Dr. Charles,
So
thank
there's
you.
some evidence to use bexatrafimab nowadays, even in pediatric, even in adults, there's some evidence to use bexatrafimab, but our center always, we go for ATG.
Okay, so Shweta will...
Right, so we
We
also
are
thought
taking ATG
of,
and a dose of 1.5 milligram per kg.
so we thought of steroid refractory rejection as well. And at this point, patient received ATG. He received a dose of 300 mg over 6 days. So after ATG therapy, he did have some decrease in his bilirubin. And for the first time, if you see this, the red line shows that it's come down to about a level of 15. And symptomatically also, again, he did have some improvement. And at this time of discharge, we kept the immunosuppression right now to 5 mg OD. And Vicelone was at 30, everolimus was 0.25 BD. We did give him Septran and Valgan prophylactic dose because he was receiving ATG. So and we thought that things were slightly getting better for him. Within the next few days, unfortunately, again he comes back with same symptoms, only worsening. He had intractable itching. Ultrasound was normal. Labs showed again a rise in bilirubin of 26. Enzymes are elevated. Alkaline phosphatase was 383. GGT was 360. The TAC level is 9.73 at this time. We sent a repeat CMV, and this time it turns positive. We had 1,500 copies of CMV. So for the CMV, we changed the prophylactic dose of Valgan to a therapeutic dose. He was receiving at 900 BD. We'll proceed. So we're in a slightly difficult situation with the diagnosis. We have treated him twice with steroids. We've given him ATG and still there's no response. So we begin to consider that there could be a component of AMR involved here. We did plasma exchange. 4 cycles were carried out. IVIG was given for 3 doses.
At this point, we want a comment from all the 3 hepatologists who have joined us on what their protocol is. Would they agree to this, or is it any different? Can we start with Dr. Joy?
Even after the biopsy proven the steroid resistant case, even the ATG, but still the patient going for cholestasis when it's not obstructing one is to the biliary. So that time the plasma exchange will help temporarily reduce the cholestasis. But usually this time we will start to counsel the family members. Whenever this kind of cholestasis, they have more chances to go for a non-protection. So the patient should not go to the sepsis, and if you get the sepsis, and they are doing plasma exchange so then very difficult to save the life. So before plasma exchange
Dr.
itself.
Joy, I'm sorry, you're not very clear.
Sorry. Okay, now it's audible?
Yeah.
It's better, yeah.
So before plasma exchange itself, we have to counsel the family members regarding the chance of going for a chronic rejection, and there are more chances to go to the liver transplantation. So we have to explain, then we can, because the plasma exchange in the post-liver transplant, there is no much RCT trial to support this kind of therapy.
Dr. Dharmesh, your views on this?
So I haven't used this at all, and like I said, this gentleman, one has to be extremely careful the path one is treading. I would, of course, at the expense of repeating myself, say that we would have had him on a higher dose of mTOR. I am not very sure, and I would like to pick others' brains on this, whether you can give somebody bacterium with the bilirubin of the level that you see in this patient. So I would not be using that drug.
And Charles?
And we don't use ATG, we use basiliximab. We used to use a lot of daclizumab, it's not available now. So no experience with this. Used it once many years ago and we lost the patient after that. It's been mainly basiliximab. Not an uncommon situation, but mTOR inhibitors are protective in this situation, so that's been our experience.
And Dr. Charles?
Yeah, Dr. Vinesh, now you have given ATG and patient has not responded, still patient probably is in chronic rejection, and our aim would be to prevent further infections and then count the patient for a retransplant. So we wouldn't use the plasma exchange situation unless because the risk of infections are high here. And the Valgan cyclovir would be used, Valgan cyclovir or Gan cyclovir to treat the patient. The patient has received ATG and is got CMA positive. Would you use IV Gan cyclovir? Probably we would use IV Gan cyclovir than oral Valgan to treat the patient. I don't know what other units or policies are.
So,
Yeah, that's correct. So if somebody is being on prophylaxis and develops a breakthrough infection, we'll switch to IV Gan cyclovir.
okay.
So this is the response to plasma exchange in IVIG. Bilirubin comes down again a little bit to 16, and then again it starts climbing up. So we keep the immunosuppression. We've changed from Advograph to TAC at 2 mg BD. Azurin has been added right now to 75 mg OD. Vislone at 20, Everolimus 0.5 BD. Next few visits were as outpatient. Patient continued to have intractable pruritus and jaundice. We decided to add bortezomib at this point, having exhausted a lot of options. We also wanted to revisit the stricture once. ERCP was done. During endoscopy, we found that he had developed 3 columns of grade 2 varices. There were 2 ulcers in the duodenum, biopsy which was non-specific. The stricture had resolved and the stents were removed. Even with bortezomib going on, the patient's bilirubin continues to steeply climb. It has reached 30. Immunosuppression at this point is 0.5 of TAC BD. The TAC level had reached 17, so we had to bring it down. Azurin was given at 75, Vislone at 15, and Everolimus at 0.5 BD.
So at this point, as Dr. Charles and all the other panelists had mentioned, we had also counseled the family that we are running out of options and probably we should retransplant. Next slide.
This time again, he was readmitted because he had jaundice pruritus. He had developed severe fatigue and weakness. We thought of a sepsis in the background. However, blood cultures, urine cultures did not show any growth. Bilirubin was 30. We decided to go ahead and do another biopsy. This time the biopsy showed cholestasis with senescent duct changes, probably involving chronic rejection was reported. Dr. Malini, would you like to comment on what were the findings in this biopsy?
Basically, it was basically a cholestatic picture, but in the portal tracts, it was actually very senescent changes. There were no tracts which showed absent ducts, but the ducts were all looking very senescent in the portal areas. So with this picture, I thought probably it is an evolving CR.
Dr. Brown, would you like to add to this? Can we have your comments on this?
I completely agree. Yeah, it looks like chronic rejection, and if we can still say that was early if the ducts are not lost. I think that's a cytokeratin on the left there, and the fact that you've got a lot of staining of cells of an intermediate hepatobiliary phenotype that goes along with bile duct damage. So yes, completely concur.
So actually, as all the panelists had mentioned, we had also discussed transplant. Unfortunately, there was no first degree relative in the family with an identical group. So he was listed for a cadaver organ. Unfortunately, in our country, organ donations are very few and far in between. So the wait continued, and meantime the patient continue to have severe cholestasis. So Dr. Brown, one question that we often see patients who have severe cholestasis as part of rejection. Have you come across such situations where the rejection presents as severe cholestasis?
Yes, yeah, it certainly can do. And once you've got the bile duct damage, if we see a cholestasis that looks disproportionate on the biopsy I'm talking about now, so if we see a lot of canalicular bile plugging and not much else, we would encourage the team to think about alternative causes. So drugs, of course, antibiotics would be at the top of the list there. So it can be part of rejection, but it's important to consider broader differential diagnoses. Yeah.
Okay, thank you. So in the interest of time, we'll have to conclude this session. So can we have the final word from the hepatologists that are they all agreeing that once you start seeing a pattern that the steroid refractory rejection which doesn't respond to ATG, do they all agree that this is the time that we should counsel for a transplant, even if there are no signs of chronic rejection? One can't conclusively say CR on biopsy, but patient is not responding to ATG. Can we have a word on that, and then we'll conclude the session?
We'll agree for that.
So do you want to tell us what happened to this patient?
Oh, he didn't make it. We listed him for a retransplant. The last slide you can read. He had a upper GI bleed. It was a duodenal ulcer. It was clipped. Following this, he had another episode of bleed and he succumbed. We could not salvage him.
So I think a couple of things. As a therapy to use that in someone who's got bilirubin values as high as this, and trimethoprim sulfamethoxazole to use in someone who's got bilirubin levels as high as this. So I think Dr. Rachel made this point that you have to be cognizant of the other confounding variables. So I think that's something I would want to reiterate. So it's well said in protocols that if someone is heightened immunosuppression, give all of these things, but one has to be mindful whether what's the level of hyperbilirubinemia a given patient has. To my mind, I don't think these drugs can be used with such high levels. And like I said, in a patient like this, we should always see if the patient is actually having paucity of bile ducts to lower the immunosuppression. So this gentleman has also been running very high immunosuppression. At times we have seen that with tacrolimus. If the tacrolimus levels are very high, you do see patients to get enzyme elevation as well as hyperbilirubinemia. So of course here I'm not saying that is what is playing, but that is again something that one has to bear in mind.
Thank you, sir. Thank you, ma'am.